A normal red blood cell circulates for exactly 120 days. To survive that long in a high-pressure environment, it has to repeatedly fold and squeeze through capillary beds a fraction of its own diameter. Hemolytic anemia is what happens when that lifespan is cut short. The red blood cell is damaged or destroyed entirely before reaching its 120-day limit. This premature death happens for one of two overarching reasons. Either the cell itself has an intrinsic structural flaw, or it is torn apart in a hostile extrinsic environment. For a clinician, determining precisely how and where the red cell breaks apart is the mandatory first step to figuring out exactly why it failed. Patients actively destroying their red blood cells present with a classic triad. First, severe anemia, a yellowing known as jaundice, and an enlarged spleen. Over time, the massive release of pigment crystallizes into gallstones. Look at this diagram showing cellular breakdown. When red blood cells are cleared from circulation, macrophages in the reticuloendothelial system of the spleen and liver dismantle them. This is extravascular hemolysis, and it produces a high volume of unconjugated bilirubin. By contrast, this flowchart details intravascular hemolysis. Here, the cells lyse directly inside the bloodstream. This spills free hemoglobin into the plasma, which eventually filters through the kidneys and turns the urine dark. Regardless of where the cell dies, a standard blood panel will show the debris. You will find elevated lactate dehydrogenase and heavily depleted haptoglobin as it binds the free hemoglobin, and a surge of new immature red blood cells, reticulocytes, pouring out of the bone marrow to replace the losses. These laboratory markers reliably prove that hemolysis is occurring. However, they are blind to the exact cellular defect causing the rupture. A red blood cell relies on three structural pillars to survive. The first is its membrane. To remain flexible, its outer lipid bilayer must be firmly anchored to a specialized internal cytoskeleton. This structural diagram illustrates those connections. In an autosomal dominant condition called Hereditary Spherocytosis, the genetic code for the tethering proteins, specifically Ankyrin and Beta-Spectrin, is defective. Without them, the membrane loses its internal support. Look closely at the spectrin and ankyrin linkages below the membrane layer. Deprived of these tethers, the cell constantly sheds pieces of its unsupported outer envelope. To conserve its volume with less surface area, the cell is forced into a rigid, spherical shape. When these unusually stiff and rigid spherocytes try to pass through the narrow capillary beds of the spleen, they become completely trapped and are destroyed. This graph maps the osmotic fragility test, the standard diagnostic tool for this defect. Because spherocytes have lost surface area, they cannot expand. Notice the distinct leftward shift of the red curve, demonstrating these cells burst at much higher saline concentrations than normal. Because the destruction happens exclusively within the spleen, surgical removal of the organ halts the hemolysis. The patient's red blood cells will remain spherical for life, but without the spleen there to trap them, the anemia is completely resolved. The second structural pillar is internal chemistry. Circulating in the blood means constant exposure to oxidative stress, requiring a robust metabolic defense system. Central to this pathway is the X-linked enzyme glucose-6-phosphate dehydrogenase, or G6PD. As shown centrally, G6PD drives a cycle producing NADPH, maintaining compounds required to neutralize oxidants and protect the cell's hemoglobin payload. Follow the oxidant pathway at the top. In G6PD deficiency, unprotected hemoglobin rapidly oxidizes and precipitates into solid clumps known as Heinz bodies.
As these affected cells pass through the spleen, macrophages bite these clumps out, inflicting permanent damage to the cell membrane. Patients missing this enzyme are entirely asymptomatic until they encounter a severe oxidative trigger. A massive, acute hemolytic episode can be induced by anti-malarial drugs, sulfonamides, or acute infections, or even ingesting fava beans. The cell's physical structure is initially perfect, but lacking its chemical armor, common physiological stressors rapidly overwhelm its defenses and trigger its destruction. The third intrinsic requirement for a red blood cell to survive is a stable, soluble payload of hemoglobin tetramers. In sickle cell anemia, a single genetic point mutation replaces the amino acid glutamic acid with valine, creating an abnormal hemoglobin variant known as HbS. Under low oxygen conditions, these HbS molecules link together, forming rigid, fibrous polymers that physically warp the cell from the inside out. These jagged, sickled cells are incredibly fragile and rupture easily in circulation, causing severe baseline hemolysis. But worse, by wedging into narrow capillaries, they create complete vascular occlusions, starving downstream tissues of oxygen and triggering severe pain crises. While sickle cell produces a defective, toxic protein, thalassemia is a problem of production volume. It is a quantitative defect where one of the globin genes isn't synthesized in sufficient numbers. The resulting imbalance causes the red blood cells to self-destruct before they even leave the bone marrow assembly line, a process called ineffective erythropoiesis. In both cases, the hemoglobin payload itself is the fatal flaw, causing the red cell to die either during its initial construction or through violent physical distortion in the peripheral circulation. Not all hemolysis is caused by a flawed red blood cell.
In many cases, perfectly constructed cells are torn apart by a hostile extrinsic environment. This peripheral blood smear reveals autoimmune hemolytic anemia, where the patient's immune system produces antibodies against their red blood cells. Notice the distinct microspherocytes. They are dense and lack a central zone of pallor, caused when macrophages strip away the antibody-coated outer membrane. The definitive diagnostic proof for this condition is the direct antiglobulin test, or Coombs test. A positive result confirms the active presence of immune antibodies, or complement proteins, bound directly to the red cell surface. Other extrinsic assaults are purely physical. In microangiopathic hemolytic anemia, fibrin strands are inappropriately deposited across microscopic blood vessels. Look at these fragmented, jagged pieces. These are schistocytes, created when normal red cells are violently sliced apart, passing through the fibrin webs. Finding a positive Coombs test or spotting schistocytes on a slide immediately reorients the diagnosis. The red blood cell is merely the victim. The true pathology lies in a malfunctioning immune system or a severely damaged vascular lining. The differential diagnosis for hemolytic anemia covers dozens of conditions, but the clinical approach to ruling them out is highly systematic. Step 1 confirms destruction using the foundational lab panel: elevated LDH, high unconjugated bilirubin, depleted haptoglobin, and high reticulocytes. Step 2 identifies the root cause, separating intrinsic structural failures like spherocytes or sickles from extrinsic assaults characterized by immune markers and schistocytes. Ultimately, treating hemolysis requires finding exactly where the architecture failed. Whether it's a collapsing membrane, a depleted metabolic defense, a toxic hemoglobin payload, or a hostile vascular environment, identifying the exact mechanism is the only way to intervene and stop destruction at its source.